Good morning, good afternoon, and good evening to you all, and welcome to this Constellations panel on the inaugural Global Drug Policy Index. My name is Colleen Daniels. I'm the Deputy Director of Harm Reduction International, and I'll be your moderator for today. Just a few housekeeping matters. Oops, sorry, I seem to be clicking too fast. If you'd like to use the attendee chat to introduce yourself and tell us where you're based and what brings you to the session, we'd love to hear from you. And please do feel free to share any comments and questions with the panelists. Questions can be addressed at the end of the panel presentations. We have Matt Wall, member of the Global Drug Policy Observatory at Swansea University, joining us today, along with John Melhouse from the Norwegian Association for Humane Drug Policies. Unfortunately, John has taken ill, but Juan will be reading out his statement. Vicky Hansen has kindly joined us from the Interdisciplinary Center for Cannabis Research at the University of the West Indies in Jamaica. And Bernice Apondi from Voices of Community Action and Leadership in Kenya is also joining us today. So what is, oh goodness, I'm sorry, so what is this about? The Global Drug Policy Index is a project of the Harm Reduction Consortium, and you can see the logos of all the members here. So it's a really diverse group of people coming together. It's a global partnership of civil society and community networks aiming to challenge the global war on drugs, which also includes the Global Drug Policy Observatory at Swansea University. The index came to be from the realization that measuring the impact of drug policy on society and on a country-by-country basis has been poorly mapped out. For decades, tracking how well or badly governments are doing in drug policy has been an intensive endeavor. In no small part, this is because data collection efforts by both governments and the United Nations have been driven by the outdated and harmful goal of achieving a drug-free society. The success of drug policies has not been measured against health, development, and human rights outcomes, but instead has tended to prioritize indicators such as the numbers of people arrested or imprisoned for drug offenses, the amount of drugs seized, or the number of hectares of drug crops eradicated. Most governments continue to employ a repressive approach to drug control based on the skewed data, which in turn means they cannot be held accountable for the damage their policies inflict on the lives of so many people. But data and a global analysis of drug policies that ultimately scores and ranks countries can change the status quo. Such a tool already exists for many other fields. We have a global hunger index, a global health security index, a global peace index, a world press freedom index, a democracy index, and there are many more. And so an interactive drug policy index is an idea whose time has come at last. At last, we have the beginnings of a tool that enables us to compare how countries' drug policies are faring in achieving the UN objectives of protecting human rights, ensuring security for local communities, securing health, harm reduction, and access to controlled medicines, and promoting development for people who grow drug-related crops. This first edition acts as a proof of concept, covering 30 countries from all regions of the world, and shows that it is now possible to hold governments to account for the devastating impacts of their drug policies based on solid, reliable, and updated data. The strength of the index lies in the fact that it does not look into policies on paper. It goes much further than that. It seeks to capture how drug policies are actually implemented on the ground, with data driven from civil society experts in all the 30 countries that are included on the index, including stories from communities who have borne the brunt of punitive drug control. As you will see, the index is a unique interactive tool that documents, measures, and compares national-level drug policies, providing each country with a score and ranking that shows how much their drug policies and implementation align with the UN principles of human rights, health, and development. As such, the index will be a much-needed accountability and evaluation mechanism with the field of drug policy, but also the basis for constructive engagement with policymakers. It is composed of 75 indicators running across 5 broad dimensions of drug policy: the absence of extreme responses, the proportionality of the criminal justice response, health and harm reduction, access to controlled medicines, and development. As you will see, I hope you can see on this chart here, Norway tops the rankings and is followed by New Zealand, Portugal, the UK, and Australia. On the other end of the scale, we have Brazil ranking last, preceded by Uganda, Indonesia, Kenya, and Mexico. Clearly, Latin America and Sub-Saharan Africa both do poorly on this index. But what's really important here is to look at country scores and understand why each country got allocated that specific score. I will shortly take you through the country scores, break them down, and give you the key takeaways of the data. The index has been developed by the Harm Reduction Consortium with strong inputs throughout from civil society and community organizations in partnership with academia. And I cannot emphasize enough how important it has been to have the voices and experiences of civil society and the most affected communities involved in this index. We owe the community a great deal of gratitude. And it's also been our pleasure to work with the Global Drug Policy Observatory at Swansea University, our academic partners on this project. But before I hand over to Matt, I'd like to show you a video. And I'm hoping that it will play. It just sets the tone, it summarizes our efforts and sets the tone for this conversation.
The Global Drug Policy Index is the first tool of its kind to document, measure, and compare countries' drug policies worldwide. Produced in collaboration with hundreds of experts from civil society and academia, the index...
Oh, what's happened? So, of course, Murphy's Law, this thing played about 90 million times before we went live, and now it won't play.
The index assesses both policies on the books and implementation on the ground.
Oh, goodness. Why don't I pause this and see if we can get it working again. If not, Matt, we'll just we'll go straight to you. Let me try it one more time. No. Okay, Matt, I'm going to just go straight to you, and you talk about the methodology. So Matt Wall is a member of the Global Drug Policy Observatory, as well as an associate professor of politics and head of the Department of Politics, Philosophy, and International Relations at Swansea University in Wales in the UK. He's going to just talk to us now about the development of the index and the modeling that underpins it. Over to you, Matt. Just let me know when you'd like me to advance the slides.
Yeah, thanks very much, Colleen. Hopefully I won't start buffering myself. It's been a long day already here in Swansea. I'd like to start off by just thanking everyone for joining us. I've been following the coverage that this session has globally in the chat. One thing I've certainly learned about working on this project is time zones and their practical reality. And so we really appreciate, I really appreciate you taking the time to join us here, and especially if it's at a difficult time of the day. So my role on the Global Drug Policy Index was part of the Global Drug Policy Observatory, as Colleen explained, as a sort of an academic partner, working with all of the various organizations in the HRC to develop the kind of technical side, I suppose you'd say, of the index. If you could go to the next slide, please, Colleen. So the logic, I suppose, that we were working with is sort of, I suppose, overall an exercise in what you'd call information compression. And that is to say that we start off with a very technically challenging and internally diverse policy area, global drug policy, as well as a very wide range of states. And so in that sense, I suppose, the index was global well, we tried to make it global in two ways. Global in terms of coverage, and global in terms of the aspects of drug policy that we integrated into a single score. Now, in terms of coverage, the resources of the project that we had were such that we were limited to being able to evaluate only 30 countries in this first iteration. It's very much our intention to expand the number of countries as the project continues, and ultimately to have a completely comprehensive coverage. In selecting the countries that we did pick, the 30 countries that Colleen showed you just now on the slide, in the first place, we used the 17 regions used by the ONDC in a lot of their reporting to kind of have that spread, I suppose, worldwide. So we have at least one country from each of those regions. We looked at, I suppose, the relevance of drug policy in each state. We looked at data availability across the states, and we also looked at the presence of civil society organizations in the domain of drug policy. And we kind of filtered the world, I suppose, through those criteria, and we ended up with the 30 countries that we did in the end evaluate. Because of the other aspect of the global nature of this project, that the sheer number of types of policy area that feed into drug policy, we spent quite a lot of time arriving at a sort of foundational document against which we could evaluate countries. And in doing so, we landed on the drug policy recommendations of the UN task team report on the implementation of the UN system common position on drug policy. That document, I suppose, provided a series of fairly concrete policy recommendations that kind of balanced, I suppose, evidence-based policy. So where there was clear evidence that policies actually worked, with an emphasis on human rights as well. And so once we determined that, we conducted a content analysis of the task team report, and from that we gleaned like every single concrete policy recommendation contained in that report. Now, some policies were policies recommended to be enacted, for example, with regards to harm reduction. Some policies were recommended not to be enacted, for example, with the death penalty. We also looked at existing data that was available that we could draw on. After quite a long process of consultation and deliberation, of which Colleen was actually a part in her capacity as a member of the scientific advisory group that we consulted with, we came up with a series of 75 indicators that combined, and I think it's important to say, that combined both the policy on the books, but also the implementation on the ground. We then organized these into a series of 21 thematic clusters of different areas of policies. We grouped those clusters into 5 dimensions that you would have seen on the video if it had played. Hopefully you can see afterwards. And we averaged out those dimensions to produce one overall score. And so that's how, I suppose, the kind of shape of this slide mirrors the fact that we had to compress all of this complexity in order to produce a single score at the end of the day. And that's the pathway that we followed. In terms of the data that we collected, Colleen, if you don't mind going to the next slide. We really had 2 types of data. In the first place, we had to kind of code or categorize or score each country on each of the 75 indicators that I just described. And these kind of broke down really into sort of formal policy, so statute on the books or policy documentation. And for formal policy, we did what's called content analysis, wherein we had a team here at Swansea literally going through the drug laws of each country and the drug policy documents in consultation with on-the-ground experts to characterize how countries performed. But we also wanted to bring implementation into the index. We thought there was quite a lot of feedback that policy on the books doesn't often bear much relationship to what's actually happening on the ground. And so we had some extant or already published data. So, for example, the INCB's SDDD measure on opioid drug access, the World Bank fair trial data, and actually several of the Harm Reduction International reports on things like the death penalty, and kind of coverage of various harm reduction interventions. However, where there were gaps, we conducted a survey of drug policy experts from civil society in each of the 30 states. And many of the scores that you'll see in the index basically reflect the average, or more technically, the weighted median position of the people who responded to our survey. And so we had 371 responses in total for the survey. And no state had less than 5 responses. That was our minimum threshold. If you could move to the next slide, please, Colleen. We also, though, had to figure out how important each individual policy indicator was, as well as how important each cluster was, as well as how important each dimension was to arrive at that overall score. This was an extremely difficult task, as many of you can imagine. And we kind of broke it into 2 sections. In the first place, we had to say for each thematic cluster, how important was each indicator. We did that by a survey of people with a high level of expertise in drug policy analysis. And we were very careful in conducting that survey to get kind of global coverage as well. So not to just have, say, a British or American or whatever perspective. For the other 2 steps, so as you're kind of getting towards the overall score, we worked with what was called our scientific advisory group. Now, the full membership of that group is listed in the report on the project website. And that process, we did something called a Delphi process of iterated weighting. What does that mean? It means that we ran a round, I suppose, where everybody indicated how important they thought each of these aspects were. We confronted everyone with what the overall score was. We did it again. We confronted everybody with the overall score again. We had a meeting where we discussed all of the arguments and kind of discourses and narratives that were behind disagreements. And then we had a final set of weights, and that final set of weights are the weights that drive the index. Just to conclude, if I might move on to the next slide, Colleen. So I think, nobody really looks forward to hearing the methodologist chat for too long, but I think it's important to talk about it a little bit in the context of this project, because I think the methodology can only really be understood in the context of what we were trying to achieve with the project. Our approach overall was to try and balance, to try and find this balance of simple but not simplistic. And so what we wanted to do was have an index that was actually actionable for people to advocate reform, to engage with the policy in their individual states on the ground, so that it wasn't sort of so complicated that actually people couldn't take much away from it. And yet at the same time, we wanted not to overly simplify what is inherently a complex policy area. And so that's why that kind of layered system that I just described to you emerged. So there are many ways you could have done this. The way we did it reflects, I suppose, the goals of the project. I think it's really important to say that the underlying values from a methodological perspective are transparency, replicability, and credibility. That is achieved, I suppose, by being as transparent as possible, both with giving everybody access to the project data set, which is available on the website. And we've also written up about a 90-page methodology, kind of going literally step by step, and every question in the survey and every step in the weighting process, so that people can engage with us, and so that they can critique us, and so that, as Colleen said, we can continue to improve this project going forward. I think finally and relatedly, in terms of developing this project in the future, we see this as an iterative, longitudinal, and responsive project. Iterative because we can't just freeze this methodology forever and just keep adding states and updating. Why? Because drug policy itself is fundamentally quite malleable and open to change. Why? Because there are ongoing academic, methodological, technical debates about measurement with which we really want to engage. And why? Because we want to see how people are actually able to use the index to advocate for drug policy reform in their states. And I think in the next iteration, all of those inputs are going to inform how we evolve the methodology going forward. So thank you very much for your time and attention.
Thank you so much, Matt. I'm going to try this one more time. I'm really horrible with technology, so apologies, but here we go. Oh, you're freaking kidding me. Okay, folks, what we'll do is we will put the link to the video in the chat, and you can hopefully have a look on YouTube and see this excellent video that everybody worked on, because I just can't seem to get it to work. Yeah, no. Okay, so I'm going to stop that, and we will get the we will try and get the link to you in the chat so that you have it. Juan, if you're able to send, oh, thank you so much. That's awesome, Suchi. Appreciate that. So thank you again, Matt. And as I mentioned already, the index actually marks the beginning of the journey to break with the traditional way of measuring success of drug policies based on skewed data focused on prohibition and incarceration. With the index, we finally have the metrics that make visible the human cost as well as the human benefits of drug policies. These are indicators that measure whether governments use extreme responses, such as the death penalty, how they prioritize the health of people who use drugs, how they ensure access to controlled medicines like morphine, and how they put forward long-term development strategies for some of the poorest communities in the world. So I'm going to share with you some of the key findings of the index and what they mean for drug policy going forward. I think the first thing is the key take-home message is that no country deserves to feel good about itself when it comes to drug policies. Even Norway, who came first overall out of the 30 countries, scored only 74 out of 100. Break that down further, and Norway scores poorly on the proportionality of its criminal justice response with a score of 49 out of 100. This is because it does not decriminalize drug use, because drug law enforcement continues to focus on nonviolent drug offenses, and because the criminal justice apparatus disproportionately targets specific groups such as ethnic minorities, women, and the poor. The same goes for Canada. It might rank 6th overall with a score of 56 out of 100, but it scores at just 34 out of 100 for proportionality of its criminal justice response. And we can also see the impact on Indigenous people, the disproportionate impact of drug policy on Indigenous people in Canada. The median score across all 30 countries is only 48 out of 100. That's a fail in anyone's book. I'd love to see any of us pass a class without getting 48 out of 100. Secondly, inequality is deeply seated in global drug policies, with the top ranking 5 countries, so that's Norway, New Zealand, Portugal, the UK, and Australia, scoring more than twice higher than the lowest ranking 5 countries, Brazil, Uganda, Indonesia, Kenya, and Mexico. This is in part due to the colonial legacy of the war on drugs approach. Thirdly, drug policies are inherently complex. This means a country's performance in the index can only be fully understood by looking across and within each of the dimensions. One of the key dimensions of the index looks into extreme sentencing and shows that 3 out of 30 countries retain the death penalty for drug offenses. So that's Indonesia, India, and Thailand. 50% of the countries surveyed reported some level of lethal use of force by the military and the police. These were regarded as widespread in Mexico and endemic in Brazil, with more than 40 cases in 2020 alone. 27 out of the 30 countries reported that the army or special security forces play some role in the enforcement of drug laws. This involvement was reported as being endemic in 5 out of 30 countries: Brazil, Colombia, Kyrgyzstan, Mexico, and North Macedonia. In 25 out of 30 countries, people who use drugs are deprived of liberty against their will in the name of drug treatment. Another key area of the index is the proportionality of countries' criminal justice response. So 24 out of the 30 countries scored below 50 out of 100 on this dimension, with Kenya and Uganda scoring particularly low at 13 out of 100 and 17 out of 100, respectively. Only 6 out of 30 countries reported no or only rare violent actions from the police in drug law enforcement. And 3 out of 30 countries reported cases of arbitrary detention as being rare, and that was in New Zealand, Portugal, and the UK. The criminal justice response continues to focus on nonviolent offenses, with over a third of countries given a score of 0 out of 100 on that thematic cluster. Only 8 out of 30 countries have decriminalized drug use and possession at national level. And only 3 of those, Colombia, Jamaica, and Portugal, have seen a reduction in the number of people who use drugs being in contact with the criminal justice system as a result of the decriminalization policy. And finally, 24 out of 30 countries have mandatory minimum penalties for drug offenses. And we all know that this is a key driver of incarceration and our prisons being overfull. A fourth takeaway from the index is that drug policies disproportionately impact people from specific groups on the basis of their gender, ethnicity, socioeconomic status, and geographical location. This can be seen to some extent across all dimensions, with countries like Australia, Brazil, Canada, Colombia, Costa Rica, Indonesia, Jamaica, Mexico, Portugal, and the UK scoring particularly badly on those indicators. The gendered impacts of drug control were reported as a trend in all Latin American countries surveyed. Another point is that there are wide disparities between state policies on paper and how they are implemented on the ground. For instance, although Russia has decriminalized drug use and possession on the books, in practice, it has entirely failed to divert people who use drugs away from the criminal justice system. All but 5 countries, Brazil, Indonesia, Jamaica, Mozambique, and Russia, have an explicit reference to harm reduction in national policy documents. But there's a huge gap between policy and implementation. For the 3 countries that achieved a score of 100 out of 100 on the policy side, so for example, Afghanistan, Lebanon, and Mexico, they scored particularly poorly on funding availability and access to interventions on the ground. 24 out of the 30 countries actually scored below 50 out of 100 on availability of harm reduction interventions for those in need. 5 out of 30 countries actually secured an adequate level of investment in harm reduction, and those are Canada, New Zealand, Norway, Portugal, and the UK. And of those, in only 1 country, Norway, is this level of investment perceived as secure. On access to medicines, countries like India, Indonesia, Mexico, and Senegal were scored high on policies on paper, while all of them were scored 0 out of 100 for actual availability for those in need. But let me say at this point that all these facts and figures are only possible because of the methodology that was employed to create the index. So, what Matt was talking about earlier. But because civil society was extensively surveyed, and it is their input that has helped enormously to paint a picture of what policy delivery actually looks like on the ground. Unfortunately, with a few exceptions, the meaningful participation of civil society in affected communities and drug policy processes remains severely limited. And this is one of the key added values of this index. We're fortunate today that we're going to hear from 3 inspiring people, from John and Vicky and Bernice. And you will hear from them about some of how they will be using this index in their countries and what it means for them in terms of policy and practice on the ground. So this index is an important starting point to turn drug policies around, but it's not about reinventing the wheel. People living with HIV transformed the AIDS pandemic from the very beginning. They now sit on government committees, advise on drug clinical trials, and are key players in current vaccine and cure development. And so, we're building on what has come before us. And we know that data should never be compromised. Sound evidence must always guide us. And that's why we took so much time and effort to ensure that our data was accurate. So this iteration of the index is only the beginning of a journey to ensure that those who construct and implement drug policy are held accountable. The more countries we can make accountable with broader and bolder editions of the index, the more likely we are to be on the way to a more humane drug policy around the world, and thereby saving millions of lives from unnecessary suffering. Good, accurate, and up-to-date data is power. It is building the evidence base, and it can help us to end the war on drugs sooner rather than later. With that, let me introduce our next speaker. So John Melhouse is project leader at the Norwegian Association for Humane Drug Policies and organizes and works with the European Network of People Who Use Drugs, who are members of the Harm Reduction Consortium. Unfortunately, John has taken ill, so Juan will be delivering his remarks. Thank you, Juan. Sorry, Juan, I can't hear you. Okay.
Is that still not working?
No, I can hear you now. Perfect.
Oh, excellent. Oh, good. Thank you so much, Colleen. I will now, can you see the slides also?
No.
Oh, I wonder if
There we go. Yes, I can.
Oh,
Got it.
excellent. Okay, thank you so much. So, yeah, as Colleen was saying, unfortunately, John wasn't well today, but I will read a statement that he kindly provided with speaking points. Many of us in Norway are really excited about the Global Drug Policy Index. At last, we have a tool that helps us measure progress in drug policy. As a EuroMPD Norway coordinator for the index, I was especially interested in the results and scores for the country. Drug policy has been a hot issue over the past years in Norway. We were so close to having a model of decriminalization for people who use drugs. The debate that led to this has been raging for many years, the product of years of advocacy and community mobilization. But the breakthrough came after a petition that we made back in 2015, where we demanded to be invited to join the official Norwegian delegation to the United Nations Commission on Narcotic Drugs, and recommended in that petition full decriminalization. 89 people from different professions, including lawyers, doctors, academics, signed the petition. Following its publication, we were invited to a dialogue meeting with the Ministry of Health. This petition had somehow inspired the Minister of Health to seek information about decriminalization. He was considered a hardliner then against any change in drug laws. In 2017, and we know from his own accounts, inspired by the experiences of decriminalization around the world, including Portugal's, he changed his mind. In fact, the government as a whole changed its mind. The Conservative Party adopted the view that matters pertaining to drug use should be shifted from the justice sector to the health sector. There were hearings and debates, and a government-mandated working group presented a roadmap of implementation towards decriminalization. What followed was difficult. The proposal gave rise to extremely heated and polarized debate in the public sphere when it comes to drug policy. And this lasted for over 2 years. The general election this year was won by the Labour Party, which decided to stand against decriminalization. So after this polarized climate, where opponents who are now in government were claiming that Norwegian drug policy was successful, while community-led organizations and allies were explaining how it wasn't successful, having an answer from the index was exciting. When the index's results came out and Norway scored the highest, you can imagine the initial response was one of surprise. How can this be? We have one of the highest overdose death rates in Europe. The police are really hard-handed and prioritize enforcement against drug users. Young people are being forced to drug testing regimes for 6 to 18 months to prove that they are, inverted commas, drug-free. And multitudes of tragedies are caused by criminalization in our country. After that initial shock, we finally understood that Norway's score is nothing to be proud of. The country, along with others in the index, do not come nearly close to the minimum baseline of rights and health-affirming policies that are laid out in the United Nations Common Position on Drugs. 74 out of 100 is 26 crucial points far from the baseline. Now, Norway has a history of championing human rights at the United Nations. The country speaks rightfully against the death penalty and extrajudicial killings in other countries. But in the field of drug policy, there is a clear flaw. When it comes to proportionality of criminal justice responses, the index shows Norway scored a meager 48 out of 100. Actually, I'm seeing it's 49 out of 100. This is behind Portugal, Jamaica, Costa Rica, and a total of 6 other countries of the 30 that have been assessed. This is precisely what decriminalization and the proposed reforms that were ultimately rejected would have addressed. And so I think this is how the index will be of help in the future. It highlights the areas that need improvement, where we're failing, and where we need to adjust our drug policies to save lives. And it may be a tool that helps not only decision makers and advocates, but also the general public to understand what's working and what is not. This index can be a learning tool. Yesterday, together with a sister organization, RIO, we handed over the report to the leader of the Norwegian Parliament Health Committee, and our message was clear. We welcome the results of the index and the companion report. We look forward to using it as a tool in cooperation with Norwegian authorities to improve the policies that have such a negative impact on the lives of so many affected people and their communities. While it is true that Norway obtained the highest score out of the 30 countries assessed, the country is still 26 points beneath the recommended baseline laid down in the UN System Common Position on Drugs. When it comes to human rights, health, and development, there can be no room for complacency. We really look forward to cooperating with partners in civil society as well as government authorities in order to improve the score, both in Norway and globally. Changing policies is a crucial step towards changing outcomes to improve the health and well-being for all, including, of course, people who use drugs. Thank you.
So much, both to John and Juan, for that intervention. We really appreciate it. So now I am delighted to introduce our next speaker, Vicki Hansen of the Interdisciplinary Center for Cannabis Research at the University of West Indies in Jamaica. The index certainly reflects a mixed picture in Jamaica, so I think we are all very much looking forward to hearing from you. Vicki, the floor is yours.
Hi, thank you. Good morning, good day, good afternoon. Let me start by congratulating the Harm Reduction Consortium on this very important and engaging work, which produced this index. In the case of Jamaica, we are appreciative of this tool. This will become a policy tool for us. It is very telling because our position of being 15 out of 30 countries and also an overall ranking of 48 out of 100 is extremely telling as we in recent times have embarked on our own drug policy reform. But our drug policy reform is limited because we have only looked at cannabis reform, and that's limited in and of itself. So that is where we start from our conversation. In disaggregating the index, we see where in terms of the use of extreme sentencing, with the amendment to the Dangerous Drugs Act, we have improved in our measures and we have gotten 76 out of 100. But this is still a challenge because we have militarized policing in some communities, traditional cannabis growing, drugs growing, cultivating communities. As recent as this year, one such community, the Akompong Maroons, which is a traditional community, faced police invasion for their participation in growing cannabis crop outside of a quote-unquote licensed regime. And the problem with this is that this is a traditional community that has used and over the years grown traditional cannabis for traditional use in their traditional cultural space. And so these are some of the things that we find problematic with drug policy and how it is implemented. It doesn't take into account the cultural rights of persons, the human rights for them to appreciate and use their culture. In the matter of proportionality, 65 out of 100 in terms of our criminal justice system. The way we look at drug policy in Jamaica, and I dare say the wider Caribbean, is on a criminal justice matter, not necessarily on a human rights health basis. And so in terms of that, we still have communities that are seen as criminalized and dissident, poor communities that are targeted in how we implement drug policy. For example, case in point, our Rastafarian communities, a number of them are still being arrested if they participate in cannabis cultivation outside of a licensed regime, which they are not used to being participating in. And the reason why we even had a change in our approach to decriminalize cannabis in the first place was because of the killing of a young man, Mario Dean, in 2015. And so you decriminalize only small possession, but in terms of participation in the drugs industry overall, from poor communities, traditional communities, there are still a lot to be done, to be desired. We would have scored 19 out of 100 in terms of health and harm reduction. The reality is harm reduction is not even on the policy agenda. It isn't even on the policy horizon as it relates to any sorts of drugs. So you find persons who participate in the use of drug being recommended by the drug courts for treatment. That treatment can be forced treatment in terms of participation in facilities that are housing facilities that they will detox and so on. So again, this is not seen as an important issue in the grand scheme of things in Jamaica. And as I said, a number of what relates in Jamaica also pertains in other Caribbean states. And so drugs policy as an health and harm reduction, that conversation isn't even starting to happen in a meaningful way in the Caribbean region. Our other critical point in terms of 35 out of 100 for availability of drugs, as Colleen had mentioned before, a number of our communities, by virtue of their social status, by virtue of their gender, by virtue of even their sexual orientation. For example, our LGBTQI community is still one community that is totally sidelined, that for various reasons are not given access to drugs, to critical drugs, to drugs that will need them to deal with transitions, to deal with various other illnesses, not to mention women who are of certain socio-economic background. They still struggle to access our healthcare system. And so when it comes on to drug policy, to treating persons who use drugs, that is still a non-existent issue in some cases. Our final score that I want to look at, 39 out of 100 for development. Now, what is very ironic about this is that when we embark and went about decriminalizing possession of small use of cannabis and also to develop a medical cannabis industry in Jamaica, a lot of the arguments were centered around development, were centered around having development for traditional communities such as our Rastafari and our Maroons and our inner city communities to get them into development. That has not, and as Colleen said before, what is on paper does not come out in the implementation. That has not been borne out in our implementation. You still have our Maroons communities who are being poor, who are outside of the legal regulated space. Our effort at creating, instead of alternative crops, but an alternative market for these communities to participate in a meaningful way in our renewed drug policy approach has not amounted to anything but a talk shop from our policymakers. And so you still find on paper we would have stated that we wanted to have a alternative development project that is centered on getting these communities to produce for the medical cannabis space and so on. But that is only on paper. The reality is these communities still exist outside of the drug policy framework. These communities also are struggling to gain some level of recognition, and the excuses that are being used by our policymakers are that we have to maintain a certain international standard because of our being signatories to the UN Convention and various other agreements like that. Now, how do we use this information? How do we move forward from this point? A number of things that we will have to look at in terms of where we are. These are, Jamaica is 15 among 30 countries. We ask ourselves, when we expand the work of the index, when we expand the implementation into other countries, where will we sit? When we include other Caribbean countries, where will we sit? This for us is an important tool for our policymakers to use to bring to their attention the need to be more focused and direct in their policy implementation, to be more focused and direct in making meaningful policy changes. The other thing for us is the inclusion of other Caribbean states, because as I said before, a number of Caribbean countries would have been following Jamaica's model and using our model to implement their policy as it relates to drug policy and more specifically cannabis policy. And based on our own experience, that is not a proper fit based on how our culture and tradition extend. We will use this policy document, this index, to also engage. So we have planned several informal dialogues with our Caribbean neighbors, one of which should be taken in occurring in St. Vincent and Grenadines in December, to say to our persons, listen, this is where we sit as Jamaica. This is where, these are the measures that you will have to put in place and think about when you're developing policy, drug policy, meaningful drug policy that does not just look at crop eradication numbers and number of persons incarcerated, but look at issues such as development, issues such as harm reduction, issues such as criminal justice and social justice system. So it is a meaningful advocacy tool for us here in the Caribbean. As it relates to the United Nations, I hope this index becomes one that they can utilize at the international level to recognize that as it relates to drug policy, the one size does not fit all. The development must be taken into account of small island developing states such as our own. But also, in addition to that, we need to create models that are fitting for the region, for the culture, and for the country. So I like to put a question in place when I do this discussion: whose development is it? And so you may have a particular development model that centers for you around crop eradication and criminal justice system, but a model for us may be better that centers around social justice, that centers around health, that centers around culture and traditional development, that centers more around our human rights. So for our perspective, we are appreciative of this tool because what it does, it helps us now as a region to look at our own realities and to apply each index in a meaningful way to say that when we are creating drug policy, when we are building drug policy, these are some of the questions that we have to ask ourselves. And this is where we rank. And so I look forward to using the Global Drug Policy Index in a wider way within the Caribbean region and also within Jamaica to prod our policymakers, not just to talk about policy change, not to just to talk about drug policy change on the books, but to ensure that in its implementation, we are able to drive the development that we so need to be more inclusive of our culture and our communities, our indigenous communities, our traditional communities, and to create models that will fit the Jamaican and the Caribbean realities. So again, I'd like to say how much we appreciate the tool. It is real and it can be applied to our everyday lives. And so we look forward to, from our perspective, to build on it, to build on the index and to utilize this index in a meaningful way. Thank you very much.
Thank you so much, Vicky. That was fantastic. And you just, you by giving us the example in Jamaica, you were able to show all those different levels that we were also trying to capture in the index, from the treatment to different approaches to cannabis. And I think one of the most one of the things I will remember from this is, whose development is this? And we're hoping that this kind of conversation will come out more, because I think one of the things that obviously we couldn't capture as well was American imperialism or colonialism in the different regions, and the legacy of drug policy, and then how our countries embrace that as if it was their own, when in fact, and then what we've done is we've actually silenced our indigenous people and traditional ways of using cannabis, for example. So thank you so much, Vicky, for raising those issues, and showing us exactly what it would look like on the ground. It is now my absolute pleasure to introduce our next speaker, Bernice Apondi from Vocal, Voices of Community Action and Leadership in Kenya, who has been at the helm of national activism in an often trying context. Thank you so much, Bernice.
Thank you, Colleen. And I want to thank Harm Reduction Consortium for this elaborate study. For us, actually, we hardly have any evidence that we can use for policy advocacy, and this is a very good advocacy tool. So first of all, reporting on drug use in Africa is not done well. If you look at the drug report and reports that are coming out from the globe, it's hardly mentioned that right now there's a growing increase in the number of drug users and also an increase in the drug trade in the continent. So we lack evidence. Even as we do advocacy in the criminalization environment, we are lacking evidence as civil society on what we can use to give to our policymakers. But what we also need to realize is Africa is filled with a lot of young people who are poor and underemployed. And then drugs have become a very good platform for young people in use and in sale. So in the last 5 years, we have seen a growing number, not just of street arrests of sellers, but also a growing number of people who use drugs in Africa and specifically in Kenya. And we are also seeing now a growing number of interest and focus in Africa, especially in terms of research, which you can now say is finally bringing out the real numbers. And probably our governments are going to take action. So when we look at this study and what we have on the ground, it is the reality that we are talking about. The legal policy barriers, the anti-narcotic laws that we have in East Africa generally. There's a lot of similarities when we talk about the arbitrary arrest, we talk about the arbitrary detention, we're talking about extortion from people who use drugs, we're talking about bribery, we're talking about torture, extrajudicial detention, and even extrajudicial killings. We have seen police just conducting swoops in drug user dens, and you're just carried away whether you have the drugs or not, and they say, he was actually walking as if he has used drugs. But then when you end up in the courts and then they find you are not in possession of anything, we have witnessed cases where law enforcement officers plant evidence on drug users, because to them, any drug user is supposed to be behaving funnily or behaving, not walking straight and things like that. So in the healthcare sector, even though a lot has been done in terms of implementation, we are still seeing a lot of healthcare-related stigma. And this healthcare-related stigma is keeping drug users away from accessing these services. The healthcare stigma is struggling the little available health services that exist. And that is something that our governments will have to deal with. The Africa society is predominantly prohibitive. We want to look the other side when we perceive something as bad. So the community has not come face to face with harm reduction and treatment. So we have seen a lot of non-involvement of the peer models in the healthcare sector. And this is what civil society has been talking about. That can the healthcare structures begin to involve communities of people who use drugs in implementation, in planning, in evaluation, in every step of the service delivery system, so that we know whether harm reduction is working and why is it not working. Because of this, we've also seen a number of dropouts, especially in Kenya. So these services go on, but we have no impact studies. We have no numbers that we can show for it. We cannot count the economic value of harm reduction, because we are not involving communities of people who use drugs. So when we want to say that it is supporting the drug user community, how are we going to say it? Because we do not have evidence. And the government that is implementing harm reduction, for example, cannot actually even tell us that this is the number of people that have gone through the system, this is how they have been helped, these are the gaps, and this is how we can fill in these gaps. So civil society organizations are still coming out, and we are still on the table saying, we need more and more community distribution points of naloxone, for example. We need more and more community members involved in peer counseling, in the planning, in the budgeting table, in the evaluation field. We need more and more community members there. So we've also seen non-existent of community-led services. It is not just involving community members, but also people who use drugs having to be part of the leadership in the service delivery. So that's why we are also having dropouts that are very high. And this is something we are talking about. So we've been talking about changing policies. And as I've said, this tool is going to help us a lot alongside others that we have in research, to sit together with policymakers and just talk about policy change. Because we've been able to collaborate a lot with policymakers in the past. We've been able to bring law enforcement officers on board. Civil society members have been able to train judges and magistrates. We've been able to have more and more community groups registered, so that they'll be able to implement programs at community level and also be able to receive funding. But this is not enough. Because as we make this our advocacy agenda at Vocal, we are now looking at leading a drug policy reform with the model harm reduction bill for Kenya. beginning maybe towards the end of this year or early next year. And we want to put all this material together to be able to speak to our policymakers. We've been able to score and dissect this index, every section of it, and for us is a true reflection of where Kenya is. We are just telling our policymakers that it is time now that we start looking for change. Healthcare in Kenya is devolved, and we are also taking this index at county level because the small amounts of research we've been able to do as civil society, we are able to partitionalize drug use in every region and just go to every country and tell them, look, you have the highest numbers of drug users in Kenya. However, the county has not put in any funding from government for harm reduction, for mental health. Mental health is very expensive, and it is impossible for somebody probably with mild anxiety disorders who has been, using drugs or just using marijuana to treat the anxiety to access the mental health services. It's close to impossible. So what we have seen is halfway implementation of harm reduction in many African countries because we lack resources, because our governments are not yet putting in enough money to help support harm reduction services. Then why are we saying it is healthcare for all if we are not giving healthcare for people who use drugs? Why is it healthcare for all if other sections of the society are not receiving this part of healthcare? At that moment, then you start questioning the development agenda, the SDG agenda of a lot of African countries, because then a big number of youths who are using drugs are out of the healthcare bracket. So for us, this is very useful. We really thank the team for reaching out to Kenya. We realized we were one of the lowest, but the situation is, we are hopeful. It is bad because we are now going towards election time and we are seeing more and more gang activity. We are seeing increased arrests of people who are selling drugs. We are seeing increased numbers of suicides. We are seeing increased number of people who use drugs. But then again, there are no increased funds to cater for the harm reduction services or services that may be needed for this specific community. So for us, it is very relevant. We are looking forward to engaging more and more policymakers, more and more law enforcers on board. And we also want to base our 2022 advocacy agenda for civil society on this document. So we thank you very much, the organizers. We thank everybody who took their time to collect their data. And for us, it's just congratulations. Thank you so much.
Thank you so much, Bernice. We really appreciate that. And I think, at you asking the question, who is the SDG agenda for if not everybody who needs healthcare can actually access healthcare. So thank you so much for that. If we can get all the speakers up now, that will be wonderful, and we can take some questions. If you please, everybody there in the audience, please put in your questions into the chat box, and we'll try and answer all of them as soon as possible. So as I'm waiting for everyone to join us, I see that Alex Stevens has a question here. And maybe Matt, you can take this one. His question is, I have a big question on this and many other indices. How much sense does it make to combine scores for very different dimensions into one overall score? Yeah,
thanks, Alex, for the question. Thanks also for the mention that you enjoy methodological presentations. It's nice to know somebody does. So this is like an extremely difficult dilemma. So to be clear, right? So I've come to this project sort of from outside of the domain of drug policy analysis. So I'm kind of I actually do electoral studies, and I'm a methodologist, right? So I kind of focus on like the technical side of the social sciences. What this experience has shown me is how important the communication of research is, and the kind of messaging that's done with it. Why do I use that setup? Because I think there is a big danger in terms of having an overall score of moving towards that simplistic end of the spectrum that I talked about in my presentation. Actually, I thought the talk with Norway illustrated that danger very, very well. And yet, on the other hand, much of the literature around how indices are actually used to advocate for policy reform indicate that a low overall score or low overall ranking can be quite beneficial for change advocates. I had to kind of do a talk on the index in Prague the other day. And as often happens at these events, my time became very restricted as everyone else went on for too long before me. And I had to kind of pare down what I wanted to say. And ultimately, what I said was, for those countries who do poorly, you should use this as a tool to humiliate your politicians into making a change. And I do think that's the dynamic that is facilitated by an overall score. But that is not without danger and risk. And I think I think it is a balancing act. And I think without an overall score, it's very hard to get the message across. But the message shouldn't just be the overall score or the ranking. The message has to be, and again, I thought the Norwegian example was a really interesting one, where you rank number one. You have to do that extra bit of digging to say, well, look at proportionality. We're only under 50. But where you rank very, very low, unfortunately, as was the case that Pernice was explaining, that kind of international censure can actually be a point of motivation for reform. And so that's the rationale, Alex. And but it's not without its risks. That I think it's important to be clear about that.
Thanks so much, Matt. So actually, Ted and Naomi partially answered this question in the chat, but Ted Nearest asked, I noticed that there are some countries that are not part of the initial 30, US, China, and Russia. Actually, Russia is included, Ted. These countries have an outsized influence outside their own border. Could you reflect on whether and how you might include them in future? So as Naomi mentioned, we want to be able to include as many countries as possible in future iterations. And the US is a really complex country with state levels, really, as Naomi said, they would need their own index with the amount of information. We did actually look at them at the beginning, but because of that complexity with the different states and the federal and state system, it was going to be extremely challenging for us. So we didn't include it. But one of the things that we did want to include, one of the criteria for choosing countries was, where do we also have civil society who are working with the consortium partners to be able to ensure that this didn't just become an index or a report that went nowhere, but actually that at a country level, we could start disseminating this information. We could do advocacy in each country. So we really wanted to ensure that that happened as well. And of course, the other issue is that we had only a certain amount of funding to be able to let us do the 30 countries. So we're really hoping that in order to bring in other countries in the future, that we will definitely get more funding to do that.
Could I just come in on that?
Did you want to add? Yes, please.
Yeah, if it's possible. So the US and China reflect two problems that are likely to come up more and more as we expand the coverage of the index. The US, in the first place, as you mentioned, the devolution of drug policy is so pronounced there. And I know we mentioned actually in Kenya as well that there's devolved elements, and in Canada, other countries we've covered. But like, say, California is so different from, I don't know, Oklahoma, that the kind of central tendency is less informative there. China, on the other hand, is a state where our strategy of civil society engagement is difficult to maintain because of the fact that civil society participation in China is extremely dangerous activity, and there's an element of ethical consideration that people like us have to make, where being involved in something like this could be literally a risk to the life of people in some of these states.
Yeah, absolutely. And, security and safety of people is of the utmost concern for all of us when engaging in the work we do at a global level. So thanks so much for mentioning that, Matt. John Firth has a question. I'm not sure how to word it better, but do you think that the world could learn from Africa? Would anyone, well, I think you worded it beautifully. Does anybody want to, maybe Bernice, do you want to start and we can all add in, or?
I think there's a lot of learning that can come from Africa. One, our youthful population, one, the poverty levels and employment, and also with a big population. That, besides any other factor, is pushing young people to use drugs. And just seeing the level at which policymakers probably don't think that these young people are important, but a population of young people can change the social environment of any country because they are not working, but they need services. And when some of these services are not provided, it can become a disaster. So yes, Africa has a lot to learn from, sometimes of how not to do things, but also how to do things very well. But again, we need our policymakers to really start thinking in reality. We are now talking about the cannabis debate. Do we need cannabis? It is homegrown here, but it is all sensational. It is all a hegemonic debate. It's all negative, you know, and nobody wants to talk about that. But we are aware that this community has been using marijuana from our forefathers. Why then does it become a crime right now when a grandfather is arrested for sniffing marijuana and he says, well, this is my tradition. So there's a lot that we can learn from our indigenous people, from our political situation and the social context and the type of leadership that we need leaders to be responding to their homegrown problems without necessarily looking at what the international scene is doing.
Absolutely. And, you know, I mean, and as a South African, I think one of the things that I would hope our politicians do in the future is to look at the laws, the penal laws, and the system of justice that we basically was imposed on us by the colonists, and then we just accepted after, you know, we became independent. We didn't look at those laws critically and say, actually, is this what works for us? Because in most of our countries, we've been using cannabis and other you know, psychedelics for years as part of our traditions, and then all of a sudden they were made illegal, and now we have overzealous governments that take money from the Americans and others to continue that persecution of our traditional ways. And, you know, I think an example of that would be Jamaica as well, with that colonial history. Vicky, do you want to add anything to that?
Yeah, you're so correct. And I want to just jump in at where Bernice left off. We could definitely learn from Africa in terms of oftentimes when we do modeling, we do our modeling based on a European colonial standard. And so we have forgotten, and so Africa is to the side. So in the diaspora, we do not, we're looking at models, and Bernice mentioned it very well. Traditionally, you have grandfathers, we would have inherited this, and this is something that we automatically would have been using cannabis in certain communities traditionally. But when we're looking at modeling our drug policy, we look at, oh, what is the US doing? Oh, so we now have this medicinal cannabis industry that is entirely built on a US model that does not take into account our own African tradition, our own measures, our own culture, our own, and so, and the reality also is that model is riddled with racism, with culturalism, all of that. And so, which my question is, when we are looking at, and we frame these in our development, and I keep coming back to my central question, whose development? Because as Bernice says, you're looking at Africa, and for over decades, we have not looked at their model and how they treat with certain issues. And the African continent has been made to feel inferior in that racial colonialized perspective that their model is not the good model. So let's go to Europe, let's go to our colonizers. And so we continually have this dialogue, but in this century, but differently, and call it something different. But to me, it's colonializing of our policies in this space. So while we have taken off the chains physically, we have those policies that are enslaving us. So when we look at even our drug policies, key to that, we are coming up with a medicinal industry that does not even take into consideration traditional herbal medicines. It's a total pharmaceutical model. So where do we now go? And so that for me is that the question of learning from Africa and looking at development has to be one that is tailored to the region, to the people, and not just transposing something from another space.
Yeah, absolutely. And Matt, do you want to add to that as well? Please go for it.
Yeah, I mean, I thought the question posed of whose development was a very apposite question to ask ourselves. I myself am Irish, as you might be able to tell from my accent, and I've observed that the legacy of colonialism is cultural and psychological far longer than the physical occupation. In terms of alternative development, for us, when we reviewed the task team report, this was by far the most problematic section, with in fact the least developed policy advice. And so we had to do quite a lot of digging in that regard. And fundamentally, alternative development, I mean, there's a reason we call it development in the index and not alternative development, is basically about moving people away from illicit crop production. And it is fundamentally just fundamentally a westernized approach. And so the way we measured it, we tried to talk about things like community engagement in the governance of these programs and so on. But I think this is where working with the UN system common position was the most problematic for us in this component. And I can only urge everybody involved in the international sphere to continue to develop the lines of thought that we're hearing here.
Yeah, I couldn't agree more. I think, one of the good things about this, and I think Dr. Paula Cubillos, I'm so sorry if I didn't pronounce that correctly, mentioned in the chat, was that in Colombia, this index is spurring a lot of discussion. And so, one of our hopes is that we are able to actually use the index to spur these kinds of discussions, to talk about the, American imperialism and forcing their drug policies on everybody and using a lot of money to do it as well. And also to really critically look at the UN, because, which office in the UN puts drugs and crime together? We have one on health, one on children, one on education, one on labor, but for drugs, we put it together with crime, and that's obscene. Why aren't we questioning these? So many governments give money to this entity to be able to keep them to enforce the treaties, the drug treaties under their mandate. And so we don't even question these things. We just accept it as the norm. But, why do we need a UNODC? We absolutely do not. Drugs should not be associated with crime. And that's how we've implemented it on the ground. And so if we can break that and challenge that thinking by using the evidence in this index, I think that's really going to start us down a path where we can change the way that we've been doing things for so long. So Glenna Rodriguez has a question. Thank you so much to everyone. What would be your advice on getting UK policymakers to change drug policy? They came up third, and do you think this high position will strengthen the government's and opposition current stance of no policy change needed? Juan, can I come to you to start us off, please?
Yeah, of course. And I think John, like the statement that John shared with us, is a really good example of how colleagues on the ground are now have the opportunity now to use the index to advance their advocacy positions, and even even in a context, in the case of Norway, the highest scoring of the 30 countries, they have managed to identify what is missing. I think that is the focus that we should, as civil society and community advocates, that is the focus that we should adopt. Not seeing this, and I know we use the expression because it's very sort of helpful and familiar, but this is not a school test. Governments cannot afford to just have half of the score. Governments are meant to have 100. Each and every government has committed to advancing human rights in drug policy, and they're failing miserably. So I think it is now the task of advocates and community organizations in the UK to look at these results and see what they are communicating. Why is proportionality and criminal justice proportionality in criminal justice responses 50 out of 100 in this country? It's because we continue to criminalize people for nonviolent offenses to a great extent, because there's crass disproportions in the implementation of the law against racialized communities. Like if we look at, for example, stop and search practices in the Met Police over the COVID pandemic, the disproportion in the impact of those practices has increased dramatically, and now Black people are 9 times more likely to be stopped in relation to stop and search powers related to drug enforcement. So we need to look at the index in detail, and I think that is the beauty of this index. Now we know exactly what is failing, and it is the role of community advocates and their allies to use this treasure trove of information for our own benefit and for the benefit of our communities.
Absolutely. I firmly agree. I think, as we saw earlier with the presentation, just because you made it to the top doesn't mean you still can't do better. And I think in the UK, gosh, we have such a long way to go. We can do so much better. Just look at Scotland, where they have the highest rates of drug overdose in the UK at the moment. Look at the issues in Wales, where, look at the issues of not all law enforcement having naloxone, or not everybody having access to naloxone. There's so many issues here that need to be addressed, and not just that, but then looking at issues around the drug policy and the impact of people who use drugs, and those experiencing homelessness, and those experiencing poverty, and those experiencing a lack of access to essential health care, like mental health care and harm reduction services, and so on. So I think here in the UK, you cannot say, we cannot allow them to say no policy change needed, because their policies are shitty anyway. So, we have to get them to change that. We've put a link in the chat. So from Matt Wall. Matt, do you want to
Could I just
have a quick chat?
speak
Yes,
to that?
please.
I mean, I totally endorse what you've both just said. Just on top of that, so this link is to the Black Report, which recently came out. And I think if every country in the world had a Black Report, we wouldn't need a global drug policy index. A lot of the evidence points that they can draw on for this report simply don't exist in many countries across the world. And they paint a really, as you said, Colleen, a shocking picture. However, I'm afraid that the state of politics in the United Kingdom, which is actually my subject of expertise, is powerless, and the elite policymakers are completely resistant to any sort of engagement with evidence, unfortunately. And I do pity anybody trying to actually engage with these people.
But we pay their salaries through our taxes, so we have to force them somehow.
Well, don't forget their second jobs. That also pays them pretty well.
Oh, yes, and their second jobs in the Caribbean. I forgot about that.
Yeah.
The sleaze of the British politician. We've got 2 questions, and I'm noting the time, so let me get to them quickly. Catherine Roldan says, "Hi, thanks for the presentation. Something was said about difficulties to gather data. I would like to know a bit more on why some countries, such as Ecuador, are not on the list." Actually, we didn't choose Ecuador in the first iteration, but we're hoping that in the next iteration, we'll be able to include many more countries from Latin America. So there wasn't, it wasn't an issue of data gathering. It was a variety of other issues that we had a chat about earlier. Kevin Brown says, "Is there any way to use the index as a guide to measure your own community? I'd like to see where the state of Georgia falls on the spectrum and use the data to enact change locally." Matt, I'm going to put this one on, send this one to you.
Kevin, this question has put a big smile on my face. Absolutely, there is a way to replicate the measurement approach developed here. So on the project website, there's a section called methodology, and there's a downloadable PDF that reproduces all of the individual indicators that we used, as well as all of the survey questions that we used to measure state performance. There's also a data set with all of the weightings that we used. So actually, it would be amazing if somebody would replicate this for some American states, and those materials are explicitly designed to enable you to do that.
Oh, Kevin, let us know how it goes, and if Matt or any one of us on the scientific advisory group can answer any questions or anything, please get in touch. I will take the last question from Kiriba Kariuki. "We are in the inception stages of policy reform in Kenya, and one of the key issues we have had to tackle is decriminalization of personal use, as well as the lack of harm reduction framework. What specific effective strategies would you recommend for effective policy change advocacy?" Bernice, over to you.
We work with Kiriba. Thank you, Kiriba, for asking that question. The strategies we have used in the past, which are very expensive, but we learned from it, but we still use it, is dialogue. We do a lot of policy dialogue with politicians. One, because the perception of drugs generally in the African society is negative. So first of all, you have to pick their brains and see, is this person in my team or they're playing for the other team? Then you try to convert the very controversial ones. Once you convert the controversial ones, you have a champion. And we have created several champions, both within and even in the region. And wherever they are, they speak publicly about human rights and healthcare. And it has helped us a lot. These are the champions that even within Parliament, in the past 2 years, we have had a lot of run-ins with the Kenya Parliament. We have had bills withdrawn. We have had bills stalled. And we've not seen any negative changes to the bill that we have, because we have been there working, collaborating, dialogue. You do a breakfast meeting, you do a lunch meeting, you're always there. And anytime they think about drug use, they think about vocal, and they think about the work you're doing, and they think about the drug users that make presentations in their meetings. So dialogue is very, very important. One, because it's friendly. It creates an environment where the other person speaks their mind openly, and then you also educate them and create awareness. And because they're your leaders, when they listen to you, to us is usually a plus, because they listen to us and they ask us questions and they say, please come in and educate us more about harm reduction. Then there's also the media campaign and, of course, public awareness campaign. In an environment where we work, there's a lot of misconceptions about drug use and drug users. So we've had to do a lot of media campaign because there's a lot of negative reporting. What you see in the social media, what you see in the media forms opinions of other people. But then when you're there and then you select a few groups of human interest stories from the newspapers, you write opinion pieces and you just train the media. It's a very, very powerful tool. And then because a lot of Kenyans listen to radio, almost 98% of people in rural areas listen to radio. They do not watch television, but even though we say that people live in Nairobi, people live in major towns, a lot of Africa populations are still in the rural areas, and radios are very, very effective, because even a simple phone like this one, which costs around $20, has a radio app in it, and people listen to radios. So when these discussions go on radios, and people get to learn, okay, so it is not good to just, be violent to drug users, to judge drug users, or so that they need healthcare. And it has helped us to form opinion over and over. I think since I started working in drug policy a few years back, many years back, up to now, we have seen a lot of change in terms of attitude. We have seen, especially from policymakers. So yes, it has helped. Actually, the president listened to one of our discussions mid this year, when we were campaigning for him not to sign a bill that was taken to parliament. And so we took lawyers and members of parliament and people who use drugs to television stations and radio stations. And he listened in to one of the discussions. And up to now, he has not assented to that bill. So we told ourselves, well done, Vocal. Yes, we did it. It was a media campaign. Yeah, so there are very many avenues that you can use. But dialogue with policymakers, you just have to map out who is important and who is a waste of my time. The very, very critical ones are the ones who are very vocal, outspoken, and controversial. Because when they buy your idea, they run with it. So it's good you do your mapping. It's good you know who your opponents are, who your supporters are. And then, of course, the media cannot be left out. Thank you.
Thank you so much, Bernice. And I know that we are over time, so the next session has started already. So I want to say thank you so much to Vicky, Juan, and John, Matt, and Bernice for joining us today. And thank you all of you who have tuned in and asked your fantastic questions and gave us such wonderful comments. Aaron Russell, yes, you should do it in Maryland. Especially Baltimore. I firmly agree. So if you do have any questions, just reach out and we'll be here to answer. But thank you so much for joining us today. Thank you to our speakers, and we'll see you next time.
Thanks,
Bye.
everybody. Bye-bye.
Thank you.